Welcome to Orthodontic Smiles, the podcast designed for all dentists and their staffs who practice orthodontics. This podcast is brought to you by the American Orthodontic Society. When Orthodontic Smiles first started, I thought it might be quite difficult to get guests to come on who had great credentials and you'd be interested in listening to. But as the popularity of Orthodontic Smiles has grown throughout the world, I have to tell you it's been a little bit easier. And one great speaker and one great person that has agreed to be interviewed on Orthodontic Smiles podcast is Dr. Larry White. What an unbelievable resume we have with Dr. Larry White. He is a graduate of Baylor Dental College in orthodontics in 1968, member of the American Dental Association. He is boarded by the American Board of Orthodontics, a fellow in the American College of Dentists. Most interestingly, he is the first director in the orthodontic program of the University of Texas Health Sciences Center in San Antonio. But that gives him one perspective. But another perspective is he was the editor of the Journal of Clinical Orthodontics for 17 years. What an unbelievable amount of information came through this man's mind over 17 years. Some of the great articles that we look to today to inspire us to do great orthodontics was first looked at by Dr. Larry White. And so I'd like to introduce to you one of our finest interviewees, Dr. Larry White. What a pleasure it is to have Dr. Larry White with us tonight on Orthodontic Smiles. I attended his lecture a few weeks ago in Dallas-Fort Worth for the American Orthodontic Society Academy of Diplomates meeting, and I sat through that lecture amazed by some of the things that I didn't know. To be honest with you, the way he constructed the lecture I thought was wonderful. So I want to thank you very much, Dr. White, for being with us.
Well, thank you. It's my pleasure.
Well, let's get into this because we've got some good discussions, I think, that we can have based on some of the things you talked about. How do you feel about orthodontics today? Is it something that you're proud of? Is it something that you thought it was going in the direction that it's going now? Or how do you feel about it now?
I think one of the biggest problems we have now is the commoditization and the trivialization of orthodontic diagnosis and treatment planning. There's a tendency to tell people, not just doctors, but to tell patients that it's very, very simple to achieve straightening of the teeth and correcting the occlusion. And that's a trivialization, I think, that misleads doctors and misleads patients as well.
Well, every doctor in America now is doing orthodontics with Invisalign. Why wouldn't the patient think that it's something easy?
Well, of course, Invisalign has spent a lot of money on their advertising, and they've convinced a lot of people that it can be done simply and easily, but it can't be, and you can go online and see the complaints that people have about the aligners. The aligners were never advertised as being efficient. They were advertised as being semi-invisible. But the patient has to wear those 24/7. And a lot of people cannot discipline themselves to do this for one reason or another. So the patient has a tremendous burden. And one of the features that the general dentists get in trouble with is if they get in trouble and the patient's occlusion gets worse, they don't have any other alternatives. They typically don't know how to use the brackets and wires because that becomes a little more complicated. So that can be a problem for them. But to give people to give doctors and patients the idea that treatment in orthodontics is just simply done is misleading, and I think dangerous.
It is a little bit scary if things aren't going well with Invisalign. There may be a tendency for these doctors to jump into something called fast braces or one of these techniques that only aligns the front teeth, and that would be totally a disservice to the patient.
Well, it is, I guess, unless the patient only wants that. But it oversimplifies. I think Einstein was the fellow who said, "Make things as simple as possible, but not overly simple." And that's true about orthodontics. And you can oversimplify it, and all of a sudden people have problems that they hadn't anticipated, and then they don't know how to get out of it. You can't learn orthodontics in just a 1 day or a 2 week course. It's too complicated. It's too encompassing. And so it's much more complicated than what people are being led to believe.
Well, your background is just amazing. I spoke about it in the introduction, but your background, and the thing that amazes me most is the fact that you're speaking to us with a background of being an editor. You were the editor of the Journal of Clinical Orthodontics. I mean, most of us, at least my contemporaries, looked at that as being the godsend of education in orthodontics, and you were the editor of that magazine for 17 years, that journal. And then you also come to us with a different approach, and that is that you were the first program director of University of Texas Health Science Center in San Antonio. So you have an educational background, and you have an editorial background. So if there's anybody that I should be asking about how they feel about orthodontics, now it's changed. I'm glad I made that the first question. Because your perspective obviously is far-reaching. So where are we making the mistakes? What aren't we learning in orthodontic therapy today?
Well, we're not learning to diagnose and treatment plan. And I read something the other day that really disturbed me because it was a survey done by the JCO, Journal of Clinical Orthodontics, and they found that most orthodontists no longer do much treatment planning. They don't do tracings of their x-rays, so then they can't do an objective treatment plan. And that really stunned me. I was amazed to read that because I trace every patient cephalometric. I do occlusograms on every patient. I spend about an hour doing my diagnosis and treatment planning. And to learn that most of the people in the profession don't do anything other than just put the brackets on and start treatment just amazes me.
Yeah, well, there's been a lot of changes in the AAO, especially in their board of diplomats. I was talking to Dr. Shaughnessy in one of our podcasts, and he was telling me about the fact that he was very impressed with the American Orthodontic Society's diplomate program because we still have to present 10 completed cases of all different types for judgment by the peers. He says that doesn't happen anymore in the AAO.
No, it doesn't. This year they've changed that. They're going to question people about their knowledge of orthodontics, and they're not going to get an opportunity to see what they've done. They've trivialized this, unfortunately, in the American Association for Orthodontists, and that appalls me. But apparently they thought that this was a way to increase the numbers of board-certified members. But, the quantity doesn't indicate anything about the quality of people's abilities. So we went from 15 patient treatments that we used to have to do down to 10, then to 6, and now to 0. So,
and you don't have to be in practice for any length of time. You can take it almost immediately.
Yeah, that's my understanding.
Yeah. Oh, that really upset Dr. Shaughnessy as well. He said after all the work I went through, um, getting my diplomate, and for them to trivialize it as they have, upset him greatly. So he was impressed by the American Orthodontic Society's relentless pursuit of excellence in our diplomate program.
Well, I think it should be a part of any board certification.
Sure, there's no question. I think we all feel that way. So these young dentists that are in orthodontic programs today, are they being taught diagnostic tools, or are they just ignoring the diagnostic tools?
I think they're ignoring them. Everybody gets a course in treatment planning, diagnosis and treatment planning, but unless those lessons are carried out at the clinical level, unless those people who are teaching the diagnosis and treatment planning actually have clinical responsibilities where they're able to apply those, then I can see how the residents, orthodontic residents, might get the idea, well, maybe it's not as important as this course we're taking. And I think that happens a lot. And so it needs to be followed up in the clinical area. And if it's not, then I can understand why they might get that idea that it's just hot air that's being blown on them because the ADA sets the curriculum and they have to take this course.
Yeah, they just feel like this is part of the curriculum, and if I can get through this and do it an easier way, then well, I think that's human nature. I think everybody's looking for an easy way to do things, but there are some things you just shouldn't shy away from, and I think diagnosis and treatment planning is one of the important ones.
Well, to me it is,
Yes.
because if that's wrong, there's hardly anything that can be right about the treatment. If you get that first feature wrong, then you're going to have trouble, and the patient's going to suffer for it.
Now, there's a lot of ways to diagnose, and there's a lot of practitioners out there. Just about every major practitioner out there is teaching a different diagnosis regime. How do you feel about that? I mean, is there some particular diagnostic method that you feel is better than most?
Well, most people are still learning to diagnose, if they're using their cephalometric tracings, to use bones between the maxilla and the mandible and lines and measurements between those two jaws. And these are hard tissue measurements. And this started with Charlie Tweed back in the 40s when he decided that the mandibular incisors were the key to diagnosis and treatment planning. And he wanted those mandibular incisors set at 90 degrees to the mandibular plane, plus or minus 3 degrees. That was pretty narrow. And in fact, it was too narrow.
Yeah, if you couldn't get them to 90 degrees, you took teeth out.
It always took teeth out. It was 4 on the floor pretty often, at least 75% of our patients back then. Of course, we were putting bands on teeth, and that made everything flare even more.
Right.
So that's no longer a problem, but still, if you're diagnosing by hard tissue, that ignores the face. And I like to diagnose by soft tissues, and that is from measurements of the face. And if the face has real good symmetry between the nose, the lips, and the chin, then we don't want to change that. And so by using the facial measurements and how the teeth relate to those facial measurements, I think we've got a much more realistic way of diagnosing, and as a consequence, we end up taking out fewer teeth. Right now, I did a survey, about 70% of my patients are non-extraction, and about 30% are extraction of premolars usually. So by using soft tissues measurements, you're gonna make fewer mistakes, I think, in the physical outcome of the patient's face.
Yeah, and I think that those of us who are real proponents of early treatment orthodontics, getting in there at a very early age, or taking out even less than 70%. In fact, I can't hardly remember the last time that I took out premolars aside from a patient that was bimaxillary protrusive and needed to have some reduction in the profile.
And
That's the beauty of early treatment orthodontics, as far as I'm concerned.
It is, and of course, the general dentist and pedodontist get to see these patients earlier than orthodontists do.
That is true.
And so you've got an opportunity to intervene, and orthodontists don't always have that luxury because we usually see these kids by the time they're 10 to 12, and sometimes that's a little late to make some of the corrections that you could make earlier without taking out some premolars.
Now, when you're diagnosing using soft tissue, are you guiding yourself more from the maxilla or the mandible? Like, for instance, the hold-away ratio is more with the chin and the incisors. How does that work with you?
Yeah, we Holdaway was the first one to make this discovery, and talked about it and published on it. He said it's not the lower incisor that's the key to diagnosis and treatment planning. Now that's what Tweed started with, and that was followed by Steiner, and that was followed by Raleigh Williams, and that was followed by Ricketts. They continued to use the lower incisor as the key to diagnosis and treatment planning, where they were going to position that mandibular incisor. Holdaway said the maxillary incisor is the one that supports the lips. That's the key. And if you get that one correct, then the rest of it can be adjusted to conform to that maxillary incisor. Mm-hmm. And so I feel like he was right. He was probably the greatest orthodontist in the 20th century.
You spent so much time in your lecture measuring the angles of the lips. I thought that was very commendable. That's something that I need to improve on, my understanding of the facial profile.
Yeah, I don't measure angles as much as I measure millimeters. Mm-hmm. And we perpendiculars from the true horizontal, and we measure the distance between the outline of the maxillary lip to the soft tissue A point. And so that's very, very important. And then there's another line that we draw from the soft tissue mandible from there to the contour of the upper lip, and we measure from that soft tissue A point out to there. And so we get a ratio, and we get an idea of how protrusive or how retrusive the profile is. Those are real important, and people can find those measurements in Holdaway's articles. And then the article by a young Argentinian in the JCO, and this was about 2000, 1999 or 2000. Freddie Alvarez from Buenos Aires wrote these articles on the A line for diagnosis and treatment planning. Those have helped me enormously, and I wouldn't want to trade those. I've used just about every regimen known to orthodontics, and I prefer the soft tissue diagnosis.
Yeah, it was very interesting to hear your perspective on that. Now, we've come a long way since the 30s and the 40s and the 50s as far as diagnosis is concerned, and I'm excited to wonder what it's going to be like in the next 20 years with the advent of 3D imaging and volume of the airway. There are some proponents out there that are stating that the new diagnostic techniques will be based on airway rather than bony or facial proportions.
That could be true. I'm not familiar with the 3D imaging because I don't have it. I can understand how it might be very useful. There are a lot of times that I would like to have it when I've got an impacted canine. And also, we're going to need to look at the airways because that becomes a problem. But there are some features of orthodontics, like the biomechanics, that they're not going to change. Those mechanical fundamentals were true 100 years ago, and they're going to be true 100 years from now. So those are features that people need to understand, and very few people do. And that's unfortunate because it can mean the difference between success and failure.
Well, let's talk a little bit about brackets. How do you feel about self-ligating brackets?
Well, a friend of mine in Switzerland who's an excellent researcher has written a book on that, and his findings were that they don't provide faster treatment, they don't provide less time in treatment, they don't provide any more cleanliness than regular brackets do, and they don't cause less discomfort than any other bracket.
So why are we spending $12 a bracket?
That was always my question. I prefer to use, most of my brackets are 0-0. I don't use a straight wire appliance.
Oh, you don't? Okay.
No, for many reasons, because you can cause a lot of problems that you don't know how to correct with a straight wire appliance. And it's an average, and there's really no average patient. So I prefer, and I use a lot of round wires, so I'm not torquing teeth with edgewise wires. I'm torquing them with round wires, and that's another technique that a lot of people are not familiar with.
Mm-hmm.
But anyway, to me, the bracket is just a handle, and these special features that are ascribed to brackets really are somewhat specious in many respects. I know my friend Tom Mulligan always used 0-0, and he's one of the finest orthodontists I've ever known, and he always used round wires. But he understood biomechanics better than the ordinary orthodontist, so he knew what he was doing and what was going to happen when he put those brackets on and when he put those wires in.
Mm-hmm. Well, you know, that majority of those brackets out there are always, most of them are Roth brackets.
Yeah.
And I think probably 99% of the time that's what's being taught, not only in most clinical programs, but in the American Orthodontic Society.
Yeah, it probably is. I personally don't prefer those simply because of the angulation on that maxillary canine. Because that maxillary canine is angulated something like 12, 14 degrees. And that can often, and very often does this, it makes the entire maxillary dentition come forward. So if you've got a class 1, all of a sudden you look in there and you've got a class 1.5.
Exactly. That's always been one of my beefs. And whenever I start a full comprehensive case, maybe you'd think it's crazy, but I put a Nance holding arch for the first 3 months, because so often I have gotten started with a case and it looked like a nice class 1, and I ended up fighting a class 2.
That's right. And
just because those cuspids draw everything forward.
Well, that happens, and it happens very frequently because people are putting on too many brackets, you see.
So that's your rationale behind putting a partial bracketing technique.
They're also using that Roth canine bracket, which is angulated too much, in my opinion, and throws the entire anterior dentition forward. And so your canine goes from class 1 to end on, or maybe even into a class 2.
Yeah, it'll do it too.
And the rest of the time trying to correct that. Now, you like to use a Nance arch, and that has solved your problem, but that gives you more expense, more time to make it. You've got a laboratory procedures you've got to go through. You can avoid that if you use partial bondings, and that's what I typically do. I very seldom bond every bracket on.
Well, talk to me a little bit about this partial banding technique that you
Well, I learned that from Mulligan, and that's in his book, if you can get a copy of that book. And by using this, you can use differential moments, and you can make a lot of progress when you use just the differential moments trying to maybe kick the molars back, intrude the incisors, open the bite that way. You can't open the bite efficiently if you've got everything bonding, but you can open the bite extremely efficiently if you only have a upper or lower 2x6 or 2x4.
Do you use a lot of utility arches?
I don't use utility arches. I use what we call a Z arch, and it works like a utility arch, but it's a lot simpler, and it's a round wire. You don't have to use a edgewise wire to do it. It gives you less force, but you can create big moments with those wires, and you can make them long, and you can advance those lower incisors and intrude them simultaneously, which is a big efficiency.
That's typical to the mulligan bend, am I right?
Yeah, that's right. That's right. So I've used utility arches, and I like them, but it's just simpler to use a Z arch, what we call a Z arch, and it's made with round wire. So it's simple to make, it's simple to apply, and a lot less complicated because with the edgewise wire you've got to torque the posterior part of that wire, or it's going to be into the gum on a utility arch.
Yes.
And that's another problem for people, and they're more expensive.
Yes. Now that if you don't want to sit there and bend them, then they get pretty expensive using the pre-made ones.
The pre-formed ones are about $10 a piece. Yeah. That's for my league.
And it does happen that way. I mean, I actually use some appliances, just the very fact that the laboratory expenses are so outrageous that if you're doing a lot of orthodontics, you basically eating up your profits.
Yeah.
Just by sending them out to the laboratory. So
yeah,
I try to make whatever I can make in my own office.
Yeah, but it still costs you in your own office too.
Sure. There's no question about it. But I'm from the old school. I learned to do all of that laboratory work and solder and bend stainless steel and all that stuff. And
doesn't intimidate you.
It intimidates most people, but I've been doing it so many years, it just takes me a couple of minutes to make whatever appliance I want to make.
And that's great. I just wish people got that kind of training now, but they seem like they don't.
No, they don't get it at all now. They don't even know how to solder a wire, none to mention bend one.
Yeah.
Nowadays, there's no bending of wires. It comes right out of the package, right into the mouth. And
I understand that.
Yeah. Well, if you had to do this all over again, if you had to sit back and say, I see where orthodontics has come all these years, and I have some advice for people out there that are pediatric dentists or general dentists or even orthodontists or residents. What advice would you give them?
Well, I would say just develop a lot of collegiality. That is, develop groups and join groups, study clubs that can help you grow and learn and prosper. And you can't do this on your own. All of us are a lot smarter than any individual. And so you need to align yourself with groups that are dedicated to continual education. And, for instance, the American Orthodontic Society provides a lot of different courses for people to learn new techniques and to refurbish their knowledge. And so you can do that, or you can start study clubs of like-minded people, friends and colleagues, where you meet once a month or maybe once every 2 months and display cases and get feedback from your colleagues about how they would treat a particular patient. That was always one of the strong features of my professional life, is belonging to groups that can help you grow.
Exactly, and that's the way I learned the beginnings of my orthodontic career was basically sitting down with 10 like-minded pediatric dentists, and all of us were put in the same room, and each of us had to present 10 cases. By the end of a weekend, you presented 100 cases, and you've gotten a chance to see what each of us was doing and what mistakes we were making, and went over the diagnosis for 100 cases. You learned quite readily by doing that every 3 months.
No, that's a good idea. I recommend it highly. I don't think there's much better way of learning.
Well, we try to do that with the American Orthodontic Society, providing a mentor program for these young students that come through our beginning courses, and they need a little mentoring. You know, they can handle a very easy case, but it can get a little bit complicated sometimes, and they need somebody that they can lean on and say, what would you do here? So I tell you, Dr. White, I want to thank you very, very much for being on Orthodontic Smiles podcast. This is probably the most technical of the podcasts we've had. We've talked about some pretty ingenious and enlightening types of orthodontic diagnostic questions and what should be done and what shouldn't be done from your perspective. So I really do thank you for being on Orthodontic Smiles. This will be, I think, one of our strong features for the next podcast.
Well, I appreciate you having me as a guest. It's my pleasure.
But on behalf of Orthodontic Smiles and the American Orthodontic Society, I'd like to thank all of the participants that have helped make Orthodontic Smiles a roaring success. We're now in almost 100 countries throughout the world and looking forward to much more success and many, many more podcasts. I will be in Kauai, Hawaii for the Memorial Day weekend. It just so happens that the American Academy of Pediatric Dentists and the American Orthodontic Society are putting on a joint symposium on early orthodontic treatment. Excellent techniques for excellent patient results. This program will provide a unique overview of how the pediatric dentist can provide early treatment orthodontics in a safe, simple, and beneficial manner. This symposium will be taught entirely by pediatric dentists who have over a century of cumulative orthodontic experience. Every aspect of treatment will be discussed, including diagnosis, minor tooth movement, crowded arches in the primary and transitional dentition, early Class 2 and Class 3 correction, with an emphasis on facial aesthetics. The pediatric dentist is the expert in facial growth and development, which uniquely positions them to learn and practice early treatment orthodontics. So we hope you will join us, along with Dr. Leonard Carapeza, Dr. Elsa Echeverri, and myself, in Hawaii, Kauai, at the Grand Hyatt Kauai Resort and Spa. That's on May 29th. It's designed to be the day after the American Academy of Pediatric Dentists closes their annual meeting in Honolulu and gives all its participants a chance to fly to another island, since we're all the way out there in the middle of the Pacific. So come and join us, and we'll be looking forward to a great symposium. This is your host, Dr. Ed Gonzalez. I want to thank you for listening to Orthodontic Smiles today. If you enjoyed our broadcast, please click the subscribe button. We'll be in touch with you in the future about our further broadcasts. Thanks for listening.